This is for EMS or those who are new to the world of emergency medicine. You need to be more afraid of scrambled brains than you are of benzos. So, when it comes to seizure, or especially prolonged seizure that turns into status epilepticus, so seizure lasting longer than 5 minutes, or multiple seizures with no return to baseline in between, um, the best, the way to ensure your patient has the best outcome is early and appropriately dosed benzodiazepines. And when it comes to EMS, that is where you people come in with your fast intramuscular Versed. So it is actually shown that pre-hospital intramuscular midazolam or Versed is better, superior in both stopping seizure and preventing additional seizure when compared to IV lorazepam, which is what we usually use once the patient gets to the hospital. So if you could load them up with some intramuscular Versed before they even get here, already you're setting them up for success. And I feel like people are scared to pull the trigger sometimes on benzos. They're worried about over sedation. They're worried about the airway. If a patient is truly seizing for 5 minutes or more, or they're truly having multiple seizures without returning to baseline, you need to treat it. Just give them the benzo. Just do it. It'll be okay, I promise. I mean, it might not be okay, but they are better off because you gave them the benzo. They are better off if you just do it. And then once they get to the hospital, that's where our emergency medicine team comes in. We need to keep going with the benzos. If they're still seizing, they need another dose. They need more. And if they're still seizing, that's when we pull our other anti-seizure meds. So we have Keppra or fosphenytoin, valproate, valproic acid, Depakote. Vimpat or lacosamide has been a popular one at my hospital lately. All of these things we have ready to go. And that's why it's good to have a pharmacist, because I know how to dose it and how quickly we can push it and what we can and can't push, what we need to monitor. Ketamine is also now second line in status or prolonged seizures. So you can give 1 milligram per kilogram IV push or intramuscularly, either. Give some ketamine. Again, if we're still seizing after all this time and you've given your Keppra, you've given all your benzos appropriately dosed, multiple doses, the airway's already gone, okay? We already need an intubation to happen. We already need a tube. So you might as well also hit them with some ketamine, okay? Especially patients who are known to drink a lot of alcohol. They already have upregulated GABA receptors, so you might as well hit a different receptor, ketamine. And then once they're tubed, you can start propofol. And if their blood pressure is not supporting all this, you might have to start a depressor. But again, if someone is really seizing for this long, you need to make it stop. You must make the seizure stop. That is the only way to ensure they have any chance of meaningful survival. Make the seizure stop. I love phenobarb in prolonged seizure, especially if you're going to tube them anyway. You might as well load them with phenobarb, 20 milligrams per kilogram. Just hit them with it. Again, all of these medications are scary in these high doses, but that's why you're in the emergency department. You have your best doctors and nurses there and a pharmacist to dose things and to tell you how quickly you can push these things. Because again, we must make the brain stop scrambling. We need the seizure to stop. So benzos, not scary at all. Scrambled brains, very, very scary.